Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Welcome, everyone. So, revisiting HIV drug resistance testing. Hopefully there will be something here for everyone, no matter how new or experienced you are to HIV care. Acknowledging our funders, and I will do my best to avoid trade and brand names. And this is what I'm hoping you get out of this talk. One is having a better understanding of the process of genotypes and phenotypes. We use those terms a lot, and I think it is important to have an understanding of what those terms mean, what the processes are, and why we tend to prefer one type over another. So we will go into what those tests involve, the pros and cons, and I'll show you some example reports. Then describing the indications for traditional genotypes. And I've used these abbreviations RT-PR partly because that's the way they show up in the guidelines. So I want you to be familiar. So the traditional genotype RT-PR, that's reverse transcriptase and protease. That's a standard genotype test that does not include testing for integrase resistance. And then many systems and labs will have a separate integrase or IN genotype or integrase resistance testing. So I'm going to use those designations, and I want you to be familiar because the guidelines use those. And then we'll also talk about indications for a phenotype. And then I'm going to go through the process of using the Stanford database to interpret resistance. And I'll talk about why I think it is such a useful tool, and I'll show you some other resources for learning more about HIV drug resistance. But first, a poll just to get everyone's brains working and just thinking. Jillian, if you wouldn't mind pulling this up for everyone. I just want everyone to think through this. I think it's an important teaching point, and again, just want to make sure everyone's sort of thinking, whether you're eating lunch or post-lunch, just want to make sure the wheels are turning. So you are seeing a patient recently diagnosed with HIV. It's their first clinic visit. They've not taken PrEP in the past. Which of the following is recommended as part of their baseline HIV routine laboratory evaluation? I've given you options, starting with genotype resistance, but integrase not necessary, then genotype resistance with integrase resistance testing, then phenotype with integrase testing, and the last option is genotype and phenotype, but integrase is not necessary. Please go ahead and weigh in, and if you aren't sure, guesses are fully acceptable. Awesome. So 80% got what I would consider the right answer. It is the guidelines-based answer, which is that everyone newly diagnosed with HIV at baseline as part of their routine evaluation should have resistance testing. It should be done with a genotype, and integrase resistance testing is not necessary. We will talk more about that. So first, what is a genotype and what is a phenotype? What are we talking about here? Let's start on the left. So a genotype is by far the most common type of HIV resistance testing you will see, you will order, or we will recommend. But what does the lab actually do? So the lab takes patient's virus, amplifies it, and sequences the genes of interest. So again, in a traditional genotype, that's reverse transcriptase and protease. And then there are options that add or include integrase as well. There's also an option to get an envelope gene genotype if someone has failed in Infuvritide, but that's incredibly rare. So really what we're talking about is sequencing genes of interest, reverse transcriptase, protease, and sometimes integrase, and looking for mutations known to be associated with resistance to antiretroviral drugs. I'll show you examples. Why do we favor this type? It's quicker than a phenotype, it's somewhat lower cost, and it's actually more sensitive. I'll talk a little bit more about that. The biggest downside is if numerous mutations accumulate, it can be challenging to interpret what resistance is predicted, but I will show you tools to help with that. Now, a phenotype I think is important to be aware of. This is absolutely still an option. You can send this, but I would say in clinical practice, it is really rare that we do this. I've only sent a couple in my career. But what's the process and how is it different? So for a phenotype, the lab will take patient's virus, amplify it, take the genes of interest, and actually splice them into a recombinant non-infectious lab virus and grow that virus in culture. Then what they do is add the ARV drugs in various concentrations until growth is inhibited. And then they will compare the IC50 of that recombinant lab virus that has basically the patient's viral genes to a wild type virus. And by comparing the IC50 basically of the concentration needed to suppress growth of patient's virus versus wild type virus, we get a ratio called the fold change. And I will show you that. So that comparison or fold change, basically if it's 1, then it took the same amount of drug. If it's above 1, then it took more drug to suppress growth of patient's virus, and that's indicative of resistance. If it's less than 1, then that would be hypersusceptible. It took less drug. So that's a phenotype. So phenotypes take longer, they're more expensive, they can be helpful if there is really complex resistance. They actually are less sensitive than genotypes because sometimes it takes a lot of mutations to accumulate before you do see growth suppressed on a phenotype. But really, this is what I want you to know. A genotype, when we say that term, what's happening is the lab is sequencing the genes of interest, looking for mutations known to confer resistance. That's all the lab is doing. Whereas a phenotype is actually growing virus, adding concentrations of drug, comparing it to wild type. Now, for both of these, the lab needs circulating RNA. There's got to be, RNA or viral load level of at least 200 or 300 copies or more, and minority populations of resistance can be missed by both of them. There used to be another option called a virtual phenotype, but that is no longer offered, so I'm not going to talk about that. So I just want to show you some examples to illustrate this a bit more. So here's an example of a report you might get from a genotype. You can see drugs, you can see resistance-associated mutations for the different classes. Here is a mutation that was found, K103N. So what does that mean? So the lab sequenced the genes of interest, and at position 103 in the reverse transcriptase gene, the amino acid K was replaced by the amino acid N. Don't quiz me on what those amino acids are, but really all that is at that position, amino acid K was replaced by amino acid N. And that is known to confer resistance to efavirenz, known from years of laboratory and clinical data. So again, a genotype looks for mutations in genes of interest known to confer resistance. Now, some reports will also have a part at the bottom where they show polymorphisms or non-significant mutations or other mutations or mutations not associated with resistance. And we don't tend to consider those or think they are clinically significant. But if you ever have a question about those, you can put them into the Stanford databases I'll show you to see if they have any effect. So that's a genotype. Here's a phenotype report. So on the left, the far left column, you can see the drugs. And then you can see a column next to that of cutoffs. These are basically cutoffs where above this range, a fold change above this range indicates resistance. And you can see here the fold change. So again, this is the ratio of concentration of drug it took to suppress basically patient's virus versus wild type. Above 1 indicates resistance. And you can see if it's above the cutoff, let's take a drug like atazanavir, then it is designated as resistant. Here's another example of a report. This is actually a type of test that shows you both the phenotype and the genotype. So you can see NRTI, NNRTI, and PR mutations, protease mutations. And you can imagine how if you see a long list of mutations like this, it's hard to interpret. It's hard to predict the resistance or susceptibility. And then you can see the fold change and the interpretation. And this was from a patient with a very resistant virus. And you can see, let's look at tenofovir. You can see how despite this long list of mutations, the phenotype showed the drug to be partially sensitive. So you can imagine if you have a long list of mutations and you're not sure if a drug like tenofovir or the protease inhibitors, darunavir or other salvage drugs, if you're not sure how much activity they have, you can imagine how this could be useful. That said, now that we have tools like the Stanford database, I would say that these have become much, much less necessary and less common to send in clinical practice. So that's the difference between the tests. I'll be happy to come back and answer questions about that. But let's turn to indications for sending resistance testing. So first, indications for sending the traditional RT, PR, reverse transcriptase, protease genotype. So as we mentioned in the poll, all treatment-naive patients at entry into care should get this test. It's recommended. That recommendation is not without some controversy based on cost efficacy, and because nowadays when we start nearly everyone on bictegravir or dolutegravir, the likelihood of finding mutations at baseline that will affect those regimens is incredibly small. However, public health uses the baseline genotypes for contact tracing and outbreak response and other purposes, and it is still recommended, and we do still do it in clinic. The frequency of transmitted mutations on a baseline genotype is 5 to 15%, but most of that is NNRTI. The rate of transmitted integrase resistance remains incredibly small, and that data is consistent across numerous studies, from the United States, from Europe, from Australia, and other places. For that reason, it is not recommended to do an integrase resistance test routinely at baseline. Now, if your lab, if your system, if the genotype you are able to obtain automatically includes that, I don't think it's a problem. I don't think you need to seek out a way to exclude that. But if it doesn't, then you do not need to add integrase resistance testing at baseline, except in unique circumstances, which I'll talk about. So you can avoid that and can save some healthcare dollars in the vast majority of instances. Now, other points in the guidelines, even if a person is not ready to start ART, it's worth checking the genotype at baseline to document any transmitted resistance. The reason is without ART over time, the wild type viruses will outcompete the resistant strains. And if you wait and do your genotype test later, it will be less sensitive and you may miss mutations. And a reminder, which we have talked about, and I think you all know, it is absolutely okay to start ART before results return from your baseline test. The other indication for genotype resistance testing is virologic failure or suboptimal virologic suppression, and I'll give you definitions for what that means. We've talked about how the guidelines have updated the definition of virologic failure to be HIV RNA or viral load rebound to above 200 copies. It used to say 500, now it clearly says 200. A note, and this is in the guidelines as well, is that some labs may have difficulty amplifying virus and performing the genotype when the viral load is low, such as between 200 and 500. But if a person has a viral load that has been suppressed and now has rebounded to that range, it is worth considering and worth trying. The other point in the guidelines is that for non-long-acting ART, so for oral ART, it is ideal to perform a genotype within 4 weeks of stopping ART. And that's to get the best sensitivity of the test, because again, with time off of ART, the wild type strains can outcompete the resistant strains, and the resistant strains may become minority populations, and the test may not pick them up. In clinical practice, though, I find that to not always be realistic. If a person comes to clinic and they've been off ART for 6 months and you have concern that resistance may have developed, I tend to think the better part of valor is to go ahead and send the test, but we will come back and talk about that a little more, and I'll show you a scenario where I think that arises. Here are slides from David Spock, which I really like, that illustrate both the goal of ART here with virologic suppression, and remember, after ART starts, the viral load usually reaches a level below limit of assay detection by 3 to 6 months. I would say with modern ART, for most individuals, this is by 3 months. And this is a depiction of virologic failure, again, achieving virologic suppression and then having rebound to above 200 copies. And this is an example of what we mean by incomplete or suboptimal virologic suppression. So if a person starts ART and you think they are taking it, you think they are adhering to it, but the viral load remains above 200 copies and does not suppress, then it may be worth repeating the genotype to see if there were mutations that were missed at baseline that then appear. Again, this assumes the person is adhering to ART. Remember the goal, what we're really looking for with virologic suppression or virologic decline with ART, we're really looking for a 1 to 2 log decrease by 4 to 8 weeks, and then a steady, consistent decrease after that to a level below the limit of detection. So if a person does not seem to be achieving that, then I have a low threshold to repeat the resistance testing. Now let's come back to the integrase genotype, the integrase resistance testing. Again, for some labs, this may be a separate order, maybe something you have to add on. That's certainly true for us in our clinic. So when do we send an integrase genotype? By far the most common indication is when virologic failure occurs for a person taking an integrase inhibitor. So if someone has virologic rebound to above 200 copies and they're taking bictegravir or dolutegravir or raltegravir or elvitegravir or nowadays cabotegravir rilpivirine, then we absolutely want to send resistance testing, and we want to add on testing for integrase resistance. The other indication that is in the guidelines is that an integrase genotype should be added to the traditional RT-PR genotype at baseline if the person who's been newly diagnosed with HIV may have had past integrase inhibitor exposure, such as receiving long-acting cabotegravir for PrEP, or exposure to integrase resistance, for example, from their partner, from their source person. So let's say a person's diagnosed with HIV and you know that the person they acquired HIV from has multi-class resistance, including integrase, then that would be an indication to send this at baseline. Or sometimes if I do a genotype at baseline and there is multi-class resistance in NRTI and protease, then I might add an integrase genotype because that makes me suspect there might be integrase resistance as well. Remember, it might be a separate order. That's easy to forget. So let's talk for a moment about this other genotype option, which has come up a lot in echo discussions. So this is a test with a lot of names. So the archive or DNA or proviral or PBMC genotype. What is this and why is it of interest? So this is a way to sequence mutations in proviral DNA in PBMCs instead of in circulating plasma RNA. The advantage is that this type of genotype can be done at any RNA level. So if you need resistance results and a person has an undetectable RNA or undetectable viral load, this is an option. However, as we've talked about before, it is clearly less sensitive than cumulative RNA genotype. So if you have the option of getting past records and getting all of a person's past traditional RNA genotype results, that is always preferred over the DNA genotype. However, there are instances in which that just isn't possible, isn't feasible. But it is important to know that studies have shown that even for groups with documented, let's say M184V on RNA genotypes, the DNA genotype may only pick up that M184V 50% of the time. So it is important to know that this test can miss mutations. So you always have to think about that when assessing results. Why is it less sensitive? There's a really nice review, this citation number 2 at the bottom from Carolyn Chu and Bob Schaefer, that really goes into this nicely. It's a very sophisticated paper that goes through all the data. But basically what's been found is that it takes weeks to months for mutations to accumulate in PBMCs at levels that are detected. So basically the mutations appear in RNA and then there's a long delay before they appear in the integrated proviral DNA and can be detected by this resistance test. That is especially true if someone has long-term low HIV RNA levels or if their periods of virologic failure were brief with relatively low levels. And so it just is not as good a test. When can this be useful? This is largely my opinion. I think the instances in which this test should be sent are if a person is clearly taking a salvage regimen, clearly or likely there is resistance in the past. You really need resistance data in order to change or simplify the regimen, and you absolutely cannot obtain the past RNA genotype results. You've tried to get records and absolutely can't. Again, it's a test we send rarely. It's important to be aware of, but not something we do routinely. So then when do we send a phenotype resistance test? Per the guidelines, the phenotype should be added to a genotype if known or suspected complex mutation pattern, but that's pretty vague. It leaves a lot of wiggle room. And in clinical practice, I would say almost never. Again, one of the main reasons the answer is almost never is because of powerful tools like the Stanford database, which I will show you. So here's a case, and again, we're going to get into using the Stanford database and how to interpret mutations, but I just want you to think about this. So a 55-year-old patient who was prescribed rilpivirine, tenofovir alafenamide, emtricitabine, presents after an absence from care. They report missed doses of ART over the prior 3 months. The prior HIV RNA levels were suppressed, but a repeat level returns at just over 1,000 copies, so clearly meets the definition for virologic failure. You send a traditional RT-PR genotype, no need for integrase because there's no integrase inhibitor in the regimen. And what returns is a report with the RT mutations K103N and M184V. So how can you obtain help interpreting the effects of these mutations? So I'd like to talk about the Stanford database and using this very powerful tool. If you're familiar with it, that's fantastic. Please share added tips and tricks. If you aren't familiar, I really encourage you to go and play with it, put in mutations. It's a great way both to get help with clinical patients and just to learn the mutations. The website is at the bottom. The key button there is the HIV DB or HIV database program. It will take you to a screen like this. They've now reordered it, so it's actually sort of vertical instead of horizontal, but this allows me to show you the options. So what you're going to do is input mutations either by typing them, using this pull-down menu, or copying and pasting them. And you need to put the mutations into the correct bucket. Are they reverse transcriptase, protease, or integrase mutations? And your report will show you that. So let's say I want to put in K103N and M184V, like from the case. I can type those. I can type K103N, enter, and then M184V, enter. I could copy and paste them if I have them in a clinical note, separated by commas or semicolons. Or I could use this pull-down menu and do M184V, and then K103N. And either way, I will make sure that they get up there in the correct category, and then I will click Analyze. And after you click Analyze, there are a few things that pop up. There's a new thing where they sort of check the validity of the mutation that's at the top. And usually, if you've been careful about your mutations, the mutations are valid, you can scroll past that. What they first give you is a predicted interpretation of the mutations. This is like a predicted phenotype, or what a virtual phenotype used to show you. So based on those mutations, what is the predicted susceptibility or resistance? So you can look at that. But what I find even more useful than that are these comments or descriptions of each mutation. Again, if you're someone who's trying to learn these mutations, you're trying to learn what an M184V does or what a K103N does, I'd encourage you to plug these into the database and read about them. And then if you keep scrolling down, this is the part that I actually find the most useful. These are called resistance scores or penalty scores. These are the tables we recreate often when talking about echo cases. And what's important to know is that a higher number indicates more resistance. 0 would be, say, no effect, no resistance. A higher number indicates more resistance. You can see the scale described at the bottom. And a negative number indicates hypersusceptibility. So for example, the top, the M184V, which we've talked about, increases susceptibility to AZT and TDF somewhat, causes low-level resistance to abacavir, and high-level resistance to FTC and 3TC, and you can see the K103N at the bottom, and the high-level resistance to efavirenz and nevirapine. So again, this is a great way both to get interpretation for patients and to learn the mutations. Let's take one more case, and I'll give you another example. So there's a 31-year-old patient who was prescribed L-vitegravir, cobicistat, tenofovir alafenamide, and tricytobine. They presented for a first visit, transferring care after moving to town. They report that due to their move and other factors, they were taking their medication every other day for about 3 months to make them last, then completely ran out for the most recent 3 months. Lab testing, including RT-PR genotype, and in this case, integrase genotype, incredibly important because this person was missing doses of L-vitegravir, demonstrate the reverse transcriptase mutations you can see there and the integrase mutations. So how would you interpret those? So again, in the HIV Stanford database, I'm going to make sure I've input those mutations into the correct categories, reverse transcriptase and integrase. And on analyzing, we'll get a predicted degree of resistance to each drug. We'll get a description of what each mutation does, and then we'll get these resistance or penalty scores. Now, again, as you can imagine, looking at a genotype report and seeing K65R, L74V, M184V, it can be hard to predict, okay, how much activity is tenofovir going to have? And you can see here a score of 40, which is intermediate resistance. You also can see here that the impact of these mutations is not strictly additive. So K65R gives a certain level of resistance, L74V, similar, M184V, similar. And then L74V plus M184V together adds more resistance to certain drugs. So it's not always a strictly additive process. The total is what we really focus on. For the integrase in this example, you can see similar, the predicted degree of resistance, a description, and then the penalty scores. Again, looking at the totals, you can see here, if I looked at a genotype, I might not be totally sure whether any of the integrase inhibitors like dolutegravir or bictegravir, the salvage integrase, whether they would retain any activity, and I can see here that they have quite high level resistance and would avoid those. So that's the power of the Stanford genotype. So take home points and I'll wrap up. So the genotype is certainly the principal resistance test used in clinical care, indicated for all at baseline, and integrase resistance testing is not routinely indicated, only indicated if you have a reason to suspect integrase resistance at baseline, such as past cabotegravir exposure or transmission of integrase mutations from a partner. Genotype resistance testing is what we send for virologic failure or incomplete virologic response. We mentioned about the importance of adding integrase resistance testing and also described proviral DNA genotypes in PBMCs, also called archived genotypes, which can in rare instances be useful for switching or simplifying salvage therapy, but do have limitations. And then hopefully this helped you get a sense of the Stanford database if you haven't used it. And again, if you haven't, I would encourage you to.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.